So I also would like to express my condolences for the passing of your late king, and I think it's particularly an honor for me to give this talk today because much of the data that I'll be talking about is actually coming from the search cohort and other important cohorts that are being followed here in Thailand. That work is really being done with Dr. Victor Valcour, who started a lot of those neurological studies a number of years ago, so I'll be presenting really on behalf of both of us. And the work here in Thailand on the neuro perspective has been largely supported by the U.S. National Institute of Mental Health in conjunction with all the infrastructure provided by the U.S. military. So all of you already know about the Berlin patient, and Timothy Brown has been mentioned several times today. And I think the important thing to think about is that once you have the goal in mind that's being galvanized by this one experiment or experience with this patient, the question then becomes, are there tissue reservoirs around the body that we need to be considering to cure HIV? This has already been raised by Dr. Chaumont in his earlier lecture. And I want to talk to you about what we know about the brain being a potential barrier to HIV remission or eradication. So what are the key questions, I think, that we have to approach? And this is a fairly young field still, so I think we're really starting to understand what the questions are and starting to develop tools to answer them. I think one of the most important questions, and I think until very recently this has been fairly controversial, is whether the brain really is, or the central nervous system really is a reservoir for HIV. Are there actually, is there a considerable amount of HIV integrated into the brain that actually could be a barrier to eradication strategies? Number two, if there is such a thing, when does this start in the course of infection? How early do we need to be concerned that the brain could be a place that HIV is hiding or that could be having effects? A really, really important thing, you just heard an absolutely fantastic talk from Dr. Chaumont about the different strategies that are being rolled out to try to address HIV remission and eradication. But I think an important consideration is what are the effects these strategies have in different tissue compartments. These strategies have been largely aimed at the CD4 T cell latent reservoir, but are there actually going to be either positive effects or even deleterious effects of these strategies in the central nervous system compartment, which actually could not only have impact on HIV remission, but could actually have clinical consequences for our patients. And finally, are there any treatment strategies that we know of now that can kind of ameliorate or reduce this reservoir and the impact of HIV in the brain? So starting out with this first question about HIV reservoirs, and I think that there are certain types of information that we can look at to tell us whether this is true. I'm going to start out with this schematic slide to give you a sense of how we think HIV really sets up shop in the brain and how HIV infection may be established. So at the bottom part of this image in the red area, this is supposed to represent the blood compartment with cells including macrophages, which are the spiky cells, and T lymphocytes that are infected with HIV. The sort of central dogma of HIV infection is that infected cells actually traffic HIV into the brain compartment, which is represented by the white area on the slide. These cells basically have the virus hiding inside them, and there is natural sort of constitutive immune surveillance that happens in all of us where our cells traffic in and out of different tissue compartments, including the CNS. In the context of immune activation and infection, there's heightened trafficking into tissues. So these cells traffic into the CNS compartment. They then release cytokines and chemokines, which are molecules that actually attract more cells. So in fact, you end up with a vicious cycle where more infected cells influx into the nervous system and inflammation is established. You have blood-brain barrier breakdown, which can also produce more of this syndrome. And finally, what we worry about is that certain cells that are resident cells within the nervous system, so tissue macrophages, which sit around the blood vessels in the brain, as well as long-lived microglial cells, which are long-lived inherent immune cells in the brain, can eventually become infected with HIV. And we know from studies of late-stage HIV infection and dementia and animals with SIV encephalitis that these macrophages and microglial cells can have quite a large amount of infection in late-stage disease. we know that the neurons themselves, which are the cells that sort of cause function of the brain, do not seem to get productively infected, but they can get damaged primarily by the release of these inflammatory mediators that come from the activated and infected cells. And finally, one measure that we can use to look for a resident local replication of HIV in this CNS compartment is looking for what's called compartmentalization. So compartmentalization is differences between the viruses found in one compartment and another. And we can test this by sampling brain tissue and looking at viral RNA there, or CSF fluid, cerebrospinal fluid, and looking to see whether the viruses found in those two compartments are different. If they're different, it tells us there's replication of a virus from a cell resident in that compartment. So I'm going to use the compartmentalization as a measure of sort of this HIV reservoir. So looking back then and thinking about what do we know about treatment, what I just showed you is what we think is happening in HIV infection prior to therapy, but the real question is what's happening once people can get onto effective antiretroviral therapy. And there's quite a lot of data suggesting that immune activation or inflammation persists in the CNS compartment despite well-suppressive, systemically successful treatment. And these are just a few different examples of the types of tests that we can do to show us ongoing immune activation. So in the upper left is a study that was done in a small number of people using positron emission tomography, which is the radioactive ligand, and you can actually use a ligand that's fairly specific for activated microglial cells. The microglial cells, remember, are the immune cells in the brain that can get infected by HIV, and their persistent abnormal activation leads to and is associated with neurocognitive impairment in HIV. So in the upper left, you can see increased levels of microglial activation in people who have been on suppressive therapy, shown in the sort of orange signal there on that slide. On the upper right, we have seen there are very few tissue samples available from people who have died while they are on very successful suppressive treatment, but a few different types of studies have shown that actually if you look at brain tissue in people on suppressive therapy, there are increased levels, in this case, of CD68 macrophages and microglial cells that are increased copious kind of in comparison to people who don't have HIV. And finally, on the bottom, some readily available cerebrospinal fluid markers can be tested to look also for persistent immune activation. One of these is CSF neopterin, which is produced by activated macrophages. So again, the cells in the CNS that we know are important that are potentially harboring HIV. And we can look to see that actually in people who are on suppressive therapy started in chronic HIV infection, there are usually persistently elevated levels of this marker CSF neopterin. And in the study by these investigators, they found that the elevated levels of CSF neopterin were found in conjunction with detecting persistently measurable HIV RNA in the spinal fluid using a highly sensitive single copy assay. So in this case, at least, it's suggesting that this persistent immune activation is keeping company with a low level of detectable virus, potentially reflecting that the immune activation is actually associated with persistent HIV. The other thing that we can look at is, I mentioned that there are very few studies that actually have looked at tissues in people who have been on suppressive antiretroviral therapy, I should say have looked at brain tissue. This is a very unique study that was done in San Francisco where people who had a sudden death in the community were identified when they had very, very well suppressive therapy, and they had agreed to be donors to look for different aspects of HIV infection. And this group, Joe Wong and Steve Euckel at UCSF, looked for HIV DNA in a variety of different types of tissues throughout the body in people on suppressive therapy. And I think they were surprised to find that actually the amount of HIV DNA found in the brain tissue was not that different from the amount of DNA found in other tissues that we think of as being typical long-lived reservoirs. What they did say is that in these studies they found very low levels of HIV RNA in the brain, so perhaps suggesting there's not that much active HIV replication, but there certainly seemed to be HIV DNA. And another very, very nice study done in Australia by Melissa Churchill looked again at people who had had autopsy specimens of brain available when they had passed away on completely suppressive therapy. And again, consistently she found in one participant out of 5 people that she looked at, elevated levels of HIV DNA. And what these different colors represent here is that when she sequenced the HIV DNA found in the brain tissue, which is the sort of purple-blue color, the sequences actually differed from the HIV DNA that was found in the PBMCs, so that these reservoirs seem to be different and distinct in the two different compartments. The other really, I think, surprising, but I think extremely important example of HIV persistence in the brain during therapy have been these recently recognized cases of CSF or CNS HIV escape. And some of you, if you are providers, may have seen patients like this. This is an example of someone who had been on very successfully suppressive systemic therapy for 8 years. So each of these red symbols on this graph represent the plasma viral load of this individual at all of his clinic visits over an 8-year period. And then at a certain point, after about 8 years, he developed a hand tremor, ataxia, slurred speech, difficulty coming up with words. And in his neurological evaluation, a cerebrospinal fluid was obtained through a lumbar puncture. And they found that despite an undetectable plasma viral load, this individual had a detectable CSF HIV RNA of about 500 copies. And when they went further and actually did a genotype on the HIV RNA that was replicating in the CNS compartment, they actually found that the resistance profile showed that this patient had developed resistance in this compartment to every single drug in his current regimen. So what this is, I think this is exceedingly rare. We term this now symptomatic CSF escape. So these are people who are fairly normal and then they develop a neurologic syndrome and they have replication. This is quite accompanied by inflammation, which you can detect in the spinal fluid and on brain imaging. In this case, the individual had resistance genotypes that were abnormal, and so we could actually change the regimen, and the patient had complete resolution of his signs and symptoms. Do I think this is a common syndrome in our patients? I do not think so. I think it's exceedingly rare, and I've done spinal taps on hundreds and hundreds of people with HIV. They don't typically have this. But this is proof of concept that at least in some individuals, this goes back, I think, to what Dr. Chaumont mentioned earlier. I think that these reservoirs or these considerations are different in different people, but it's proof of concept that despite extremely effective systemic therapy, you can have HIV viral replication in a tissue such as the CNS. In a case of this CNS escape, one of the really important questions is what type of cells are producing this virus that's replicating in the CNS? And I think that one of the interesting experiments that's been done recently by some colleagues at University of North Carolina is looking at samples of CSF escape. And so on the left here is a graph of an individual who had plasma viral load after starting treatment, became undetectable and was suppressed in the red. But the blue lines on the graph on the left show two different episodes where there was CSF escape in conjunction with suppressed plasma. And when the individual's CSF virus was tested for its ability to infect cells with low CD4 density, telling us that it seems to have modified itself to potentially replicate in macrophages. They found enhanced ability to replicate in a macrophage from this escape virus. So it's suggesting that maybe this escape virus was potentially hiding in an infected macrophage in the brain. But there's a lot more work that needs to be done to understand this. In terms of then this reservoir for infection that I think we have evidence that occurs in at least some individuals with HIV, when do we think this is established? And this is really where the studies that we've been doing in Thailand in conjunction with Search and the US military have really, I think, been important. So what we've been able to do is obtain not only plasma, and this is the plasma viral loads from participants both in the Search study in the first about 30 days of this graph, and then in another study that we ran in San Francisco of early infection, showing the sort of typical trajectory of plasma viral load in acute infection and then a set point. And what we've done here is superimpose upon that the CSF viral loads that were obtained in the same participants at the same time points. And just to focus on the CSF, I think what you can see is that although there are a number of people in this group that actually have low or undetectable levels of CSF HIV in the first 12 months of infection, there's some people that really have a very high viral load, especially in that acute infection period. And in fact, we had some people in the viral loads in the millions per ml in the first month of infection. So I think that's telling us that the virus is entering the CNS compartment very early, that it's not a protected, privileged site where a virus isn't entering. I also mentioned earlier the molecule CSF neopterin, which is a marker of macrophage activation. So again, this pathogenic sort of process that's being initiated in the nervous system is really reflected by things like this macrophage activation. It's also potentially a site that could be infected in the brain. And this graph shows the normal level of CSF neopterin in HIV uninfected controls as the dotted line in the graph. And almost all of the CSF neopterins from these two studies were elevated in this acute period of infection. So you're really setting up shop, I think, for something that is potentially associated with this neuropathogenic process within the first weeks after people acquire HIV. So I mentioned that sometimes we look at compartmentalization to understand when the virus is actually being produced in the CNS compartment compared to the blood. That compartmentalization is the difference in viruses between those two different compartments. So one of the sets of experiments that we've done is look at whether or not, if you look at people's viruses in the spinal fluid versus the blood in this early period of infection, can you detect this a beginning compartmentalization? We know this compartmentalization happens in late stage disease and dementia, but we didn't know how early it could happen in the course of infection. And what we found was about 25% of the viruses we tested in this sort of 4 to 12 month period actually had evidence of compartmentalization. And we had some individuals where we had multiple values. This is not in the search study where everyone's treated in acute infection. The San Francisco study, some people didn't start treatment for a number of months or even years. So we had samples over time where we were able to compare the sequences between the spinal fluid and the blood. And this is one example where we had relationships between the blood, which is shown in the red, and the spinal fluid viruses, this is the envelope sequence shown in the blue, actually diverged. There was one sort of set of sequences that diverged from the blood at about 4 months post-estimated HIV infection and continued to evolve. This is the area shown in the sort of blue swath up in the upper right. These were only found in the CSF compartment and evolved within that compartment over the first 2 years of infection. So what this is telling us is this is the earliest sampling we did in that study. This is telling us that actually compartmentalization and evolution in the CNS compartment can start within the first year. We're looking now with very sort of deep tools and high-resolution tools to look at the same data in the spinal fluid in the search cohort, which is much earlier. And I can tell you that some of that will be presented by one of my Thai colleagues, who's an infectious disease doctor here at Siri Raj Hospital, worked on that project and will be presenting it as an oral presentation at CROI. So that will be really fantastic, and it's available on a webcast to watch, including Dr. Jintanat's talk. So the last two sections are a little bit shorter. It's really sort of talking about these big picture questions. How will cure strategies affect the brain? And I think this is really where we've been so fortunate to collaborate with all of the investigators that you're hearing from today, because we all work together trying to look at what these cure strategies may do systemically and then what they may be doing in these other compartments. And again, this is thanking all the collaborators and the staff and the team that are here, also thanking our generous participants, because not only do they take on cure studies and think about them, and we'll hear more about that decision making today, but many of them are also willing to have sampling such as spinal fluid sampling and do MRI scans to give us a snapshot of what's happening in the brain over time. So what we've been able to do is team up with the collaborators here and say, if there's a specific cure study that's happening, these are usually people who were started treatment in acute infection, they've been on suppressive therapy for a while, they're going to have some type of a remission intervention, and then some of these people will interrupt therapy. And what we've been able to do is say, let's continue to monitor the nervous system during those interventions at all those different stages, looking at spinal fluid, neuroimaging, doing neurologic exams and evaluations to really give us a sense of how this may be affecting the CNS. And these studies are just starting, but we've had one very nice example, and this is, again, in collaboration with Search and also with Dr. Mark D'Souza, who's in the room, who initiated a study to look at a particular combination of medications, vorinostat, hydrochloroquine, and maraviroc, to look to see whether there may be an impact on HIV reservoirs and rebound after treatment interruption. So what we were able to do here is to show that if we follow the participants at multiple time points, the upper left graph is the change in the plasma from the baseline before the intervention. the time during getting the intervention, which is termed week 10 VHM, during treatment interruption, and then back on therapy. What we were able to do here is show that the CSF viral load, and this is using a very sensitive single copy assay, didn't seem to change in the small number of people that we had during the intervention, but did start to go up during treatment interruption, which we know happens with treatment interruption in the CNS. We also showed that there was a hint that CSF protein, which is a blood-brain barrier marker, seemed to go up a little bit in one person during this intervention, and certainly signs of inflammation. This is a chemokine, immune activation kind of marker in the bottom right, went up with treatment interruption. So this actually, overall our interpretation of this study was very safe for the CNS, but I'm showing an example of how we can start to use these tools to answer important questions about the consequences of these interventions and these kinds of studies in the brain. And finally, are there certain treatment strategies that benefit the brain? And I think one of the takeaway messages is, despite it not being adequate to eliminate reservoirs, to eradicate HIV, starting treatment early clearly seems to have a benefit in the CNS compartment. And I would say that most of the outcomes we've had for that have been based on sort of big picture outcomes such as clinical outcomes. We have a marker that we can look at in spinal fluid, which is called neurofilament light chain. It breaks down, or it becomes released when neurons are injured. And this is a study that we did here at Search comparing people's breakdown marker of this neurofilament light chain in the spinal fluid if they were treated in acute infection or if they had been treated in chronic infection. That's shown in the upper left, and what you can see is people who were treated in acute infection had essentially normal levels of this marker, suggesting no active neuronal injury after therapy, whereas people who were treated in chronic infection, despite 2 years of treatment, actually had elevated persistent levels of this marker, suggesting low-grade neuronal injury ongoing. We've also did an early study in Search where we looked at cognitive outcomes in people during acute infection and then after 4 and 6 months of treatment. And what we found there was that actually they had essentially normal neurocognitive, for the most part, most of the people had normal neurocognitive performance. There's a nice study that was also done in New York City looking at people who had been treated in primary infection, not acute infection, finding that people who were treated in early infection and then followed over a number of years really had normal neurocognition compared to controls. So in terms of neurological and neurocognitive outcomes, starting treatment early I think has a benefit. What we don't know is whether or not it has enough benefit to really reduce reservoirs, and I think that's really where our next set of research is going. We also know that people should stick to treatment, and I think this is old data but compelling data, and it's a little bit, gives us pause when we think about treatment interruption studies. This is an old study from Dr. Price and Steve Deeks at UCSF from 2004 showing that you have not only plasma viral rebound with treatment interruption, but actually CSF HIV rebounds very high with treatment interruption. And maybe more concerningly is that with treatment interruption, you can have a lot of neuroinflammation. So this is the CSF white count, which is a clinical measure of neuroinflammation. What I would say is that in comparison to these types of treatment interruption studies, where this is days after infection, people are kept off of therapy for a long time, what we've seen so far in our treatment interruption studies is that if people are closely monitored and started on therapy early when they have very low plasma viral loads, we haven't seen this type of inflammation. But certainly for patients in the community to just go off therapy is likely injurious in the brain. And finally, I think, and this is, again, going back to this question, is are there certain medications that are important to select to try to treat the tissue reservoirs? And many of the studies that have looked at exposure of drugs in the central nervous system have really focused on whether there's a clear impact on neurocognitive outcomes. As a clinical question, that's been the big question in the community and in the field. And those studies have had mixed results. So there have been some studies that have said when certain drugs are categorized regarding their potential ability to, for example, cross the blood-brain barrier or their detected levels in spinal fluid versus blood, they can be categorized as high CNS penetrating or low CNS penetrating drugs. Many of those studies have not shown a beneficial impact in terms of cognitive outcomes or other things. Some studies have shown that drugs with higher CNS penetration do result in a lower CSF viral load. So maybe that actually is related to the fact that this is getting into the tissues and is important for this reservoir. But the neuropsychological performance has been more mixed, and I think part of the reason may be the design of those studies. Many of them have not been prospective, they've been cross-sectional, and also neuropsychological performance has more sort of confounders in terms of evaluations. There is some early data to suggest that monotherapies and dual therapies, which have been turned to in a number of different settings, especially in Europe, have a higher risk of CNS escape. So again, I think would confer a risk of increased reservoir replication. And also there's a possibility of increased neurotoxicity of some antiretroviral therapies, which may have also a concern, because if there's neurotoxicity, even if it's effective in the brain, we also may having, it's a yin-yang of what's causing damage. So I think this is really an area that needs to be considered, and I think should be considered with the specific question of reservoirs in mind, not just the cognitive outcomes. So this is my last slide, and I think what I hope that I've showed you is that I think that at least in some individuals there is evidence of a CNS reservoir. We also know that the brain in the CNS compartment is impacted very, very early in the course of infection. So I think we do need to be considering the CNS compartment in strategies when we're thinking about HIV remission. We hope that most of these interventions that are going to be remission interventions will be safe, but we need to look at them carefully. I think the next set of questions, I mentioned that Dr. Rujipas from Siri Raj Hospital will be presenting a study that looks at very, very acute HIV and compares the CSF and the plasma, and we have new findings to report on CROI at that. Another question is, I mentioned that early treatment in acute HIV is probably very beneficial in terms of cognitive outcomes, but is that truly enough to prevent the reservoir establishment in the brain? And I think, again, there are a couple of presentations at CROI that will be coming up, can be watched on webcast or available online for all of you, that really shows some of the really important data that's come out of the studies here that will help answer this question. We're doing a study here looking at adding an adjunctive anti-inflammatory therapy, which we hope will impact not only immune activation in the periphery and the CNS, but also lymph node fibrosis. And I think that is one approach to dealing with the fact that much of this sort of milieu in the CNS compartment that fosters more infection and injury is related to inflammation. And finally, I think going forward with additional studies of how treatment interruption and how these intervention therapies will affect the brain is really key. So again, I want to thank, in particular, the study participants. We talk about giving blood, we talk about involving, doing surveys, but I think that the participants who are willing to have lumbar punctures, who are willing to be in an MRI scanner, are really giving something which is way beyond the call of duty for something that is not necessarily to their benefit. So I want to thank them greatly. I also really want to thank all of our colleagues here, and particularly Dr. Jin Tanat and Dr. Victor, who I think I have been so fortunate to be able to be involved in these studies, because I think we're answering really important questions with a fantastic team. And I also really want to thank the support that we've gotten from our colleagues at the U.S. military, from NIAID, and in particular from the National Institute of Mental Health in the USA, who have pretty much supported all of the studies regarding these questions, and I think are going to make big contributions through their support. So thank you very much for your attention.
Thank you so much.